CataractCoach.com. White cataract drops into the vitreous. See how this case happened and how it was recovered. Our guest surgeon, Dr. Zahar Al-Doush from KSA. So here's the case. A white cataract looks intumescent, and a great incision being made here, sitting temporal, nice draping, eye in primary position. Here comes the trypan blue dye. Of course, that's required for these white cataracts. And this is a surprise case. So I really enjoyed watching this video from Dr. Al-Doush because it showed a complication in how it was managed. So after staying in the capsule here, the dye can be washed out, and the eye will be filled with viscoelastic, and a capsulorhexis will be created. And so here comes the viscoelastic, dispersive viscoelastic going inside here, getting a nice fill in the anterior chamber. That looks great. You can see the intumescent nature of the capsular bag. And so nice, good pressure. You check the pressure to make sure the AC pressure is on the high side. Going in with a needle for a needle decompression. Let's take a look here. Bevel down, entering in the center, decompressing, aspirating out that milky liquefied lens cortex. Very nice technique here, taking that out. And now, let's see, rocking the nucleus maybe, more viscoelastic. And you can see a rhexis can be created. Now the anterior lens capsule has been flattened. The incision can be now opened up to the full width. And the utrata forceps or similar forceps can be used to create a nice capsulorhexis. So first, even more safety, double rhexis technique here. Starting off with that small, tiny rhexis so that the capsular bag can be fully decompressed, and then that can be expanded. And so now, once that's in control, he's going to expand it out and spiral it to the desired size. So in this case, didn't need to really manipulate the nucleus much. And you can see that's a very nice rhexis. Of course, that's super important in a case like this, where you may end up with a sulcus lens or alternate form of fixation. So releasing a little viscoelastic here. And now slight hydrodissection. Usually in these cases, not too much hydrodissection is needed because the cortex is already liquefied. So just rotating the lens around, it looks like it's pretty free. Now here comes the surprise. The surprise comes when the phaco probe is placed in the eye. So a little more viscoelastic to protect the tissues. And let's see the technique here. Side port incision being made there. And another one on the other side. So maybe we'll do bimanual cleanup at the end there for the cortex. So 2 paracenteses. Here comes the phaco probe. And we go. And let's see the nucleus removal technique. Here comes the chopper as well. Ball tip chopper. And vacuuming, going into the nucleus. Let's see, embedding the probe, going in for a chop. That's a good embedding of the probe. Beautiful technique. Chopper goes around the lens equator. Nice horizontal chop coming up. Let's see it. Oh, yes, satisfying. Very nice chop. Nucleus has been chopped, but look carefully as the pieces are split together. Whoa, look at that ominous sign right there. The persistent gap, and whoa, what just happened? You just lost a half. The posterior capsule was wide open. Importantly, keeping the infusion on inside the eye, trying to save that second piece. It's gone down too. Should you fish for these pieces? No, leave them alone. Don't do anything crazy. Be cautious and follow Dr. Al-Doush. He's doing a beautiful job here, putting in the viscoelastic. And this patient's going to need a pars plana vitrectomy lensectomy. There's no doubt about it. Those 2 pieces of the nucleus are in the vitreous cavity. So here's a bimanual anterior vitrectomy, cleaning up any prolapse vitreous. Do not fish for those pieces. The proper way to get them is pars plana. And let's watch carefully. So cleaning up, nice, cleaning up the anterior segment. All the cortex has been removed. Look how the capsule has been preserved. Now, through the pars plana, a proper vitrectomy and pars plana lensectomy. This is the way you should do it. Now, I'm not a retina surgeon. I wouldn't normally do this. I would send these out to my retina colleague to do instead. If you have the training like Dr. Al-Doush to do both anterior and posterior segment surgery, well, then certainly you can do that. So beautiful cleanup of that dropped lens nucleus, and now coming in here for a sulcus lens. Here's a 3-piece IOL. That looks great. Good orientation of the haptics. That can be placed in the sulcus. Dial that around nice and easy. And if desired, you can even try to capture the optic. So the important lesson in this case is everyone breaks the capsule. That happens to all surgeons. Every surgeon also will drop the nucleus. That happens as well. You can't always predict patient tissue. The surgery was done beautifully here. The patient had the issue with the bad tissue. But you have to know to not fish for the pieces. Instead, let them go back, and the patient deserves a proper pars plana vitrectomy and lensectomy. Here at the end of the case, a beautiful result, and the patient had an outstanding visual result. So thank you, Dr. Aldouche, for a very nice case. I learned a lot.